Welcome everyone. I realize many people are running late. We have a big traffic rearrangement going on out on I-80, and I think we'll have several people joining the meeting late, but we should just get started. I want to welcome all of you. Thank Liz Helms from the Chronic Care Coalition for stepping in to help with the logistics of the meeting in the absence of our normal coordinator who's off enjoying her fiance's family in Ireland. So Carla will be back with us for the summit. I want to remind everyone that we will not have a regular University of Best Practices next month. We will not be reconvening the University of Best Practices in this room until December the 8th. And at that time, we will have with us one of the award winners from the summit who will be relaying their best practices. And I will be writing to you about that. So in the meanwhile, enjoy your meals, and let me introduce Dr. Ludlow, Dr. Erdl, to co-chair the meeting. Thank you.
Okay. Well, thank you, and welcome again to this really exciting, I think, agenda. We have a lot to talk about today, as usual, and wanted to, first of all, take the opportunity to introduce our first speaker, Martha Garrity. And Martha and I actually have been working together for quite a while, and she's got a great bio with clearly in her bio. I won't really go into any detail because you can read it, but I just want to say, Martha, it's really great to have you in Sacramento and all the great work that you're doing. And we've worked together on diabetes and heart disease and a variety of other issues for several years, and she was instrumental in us putting together a Latino Diabetes Health Forum that we did a few years ago, and it was a really good success, primarily because of Martha's connections and her ability to bring the community together. So I wanted to, again, thank you for that, Martha. So Martha's going to talk to us about a new program with her partner, HealthNet, for Healthy Hearts and Healthy Living campaign, and we wanted to, again, thank you for all the work that you do in our region.
And I just want to say thank you for bringing your innovative program from HealthNet to share with the Sacramento region.
Thank you. First of all, I guess I wanted to start out by, my bio says what I've been doing for the last 25 years, but it's really important to understand kind of who I am and where I'm coming from. I'm a Sacramento native. My kids are fourth generation Sacramento, so my family and I have been very, very dedicated to this community. I worked at UC Davis. Well, first I worked at UCSF in multicultural health, handling all the Speakers Bureau multicultural health fairs. And then I transitioned to UC Davis, where I directed the outreach and created the outreach and division of diversity and aging at UC Davis for 10 years. And my passion has been working with older adults from diverse ethnic backgrounds and providing kind of one-stop services for them to obtain information about health care and how to navigate the health system. I started a HealthNet 8 years ago, where I direct the health education programs for Northern California. My counties are Sacramento and Stanislaus and San Joaquin, and last year I developed the Healthy Hearts, Healthy Lives campaign. But I really wanted to address this from a very personal experience. And I think in this room I have been the one person who might not have a lawyer degree or an MD degree or a nursing degree behind my name. But I have a lot of experience in working with the diverse populations that we serve, the low-income communities, and also in the family journey, the patient journey of heart disease. She was a devoted wife, a mother, a best friend. We all have that in our lives. A professor with a lifetime of experience who impacted the lives of the population she served. She was the Sacramento pioneer, a founder of over 10 multiple community-based organizations that serve children, that serve babies, that serve pregnant women, that serve our Latino community, that serve students. She never had a risk factor for this devastating disease that would ravage her body and destroy her heart. She never smoked, never had diabetes, had low blood pressure, lived a relatively stress-free life. Her body was her temple. She was disciplined. Her middle name was Discipline. Always monitoring what she ate, swimming a half-mile a day. Each day, swimming was the love of her life. We are her 4 daughters with over 100 years of experience combined in healthcare. Social service director, hospital administrator, gerontologist, educator, and health insurance expert. That's my other sister. We understood how to navigate, how to advocate for her. We understood the system of healthcare. We knew what it meant. We knew what to do. It was we, her 4 daughters, who understood and knew what to do when our mother, who had had an infusion for a skin infection, went in for an injection and ended up with an infection in her heart. It was we who understood the abbreviations for the skin disease, the MMRS. We understood what endocarditis meant. We understood when she took her first walk after 2 years of hospitalization and she could not breathe. It was our years of experience and knowledge of healthcare that could never have prepared us for this journey, this 1.5-year personal journey, our family journey of heart disease. An aortic valve replacement, a mitral valve repair. An 80-year-old woman who 2 months before had swam 40 laps a day, and her body was her temple. When they opened her up, the surgeon said her heart looked like that of mine, a 50 or 60-year-old. Her heart was healthy. She needed only 1 bypass. Throughout this process, she had a pacemaker. She had a crash cart roaring into her room 4 times to save her life. The multiple hurdles, the tests, the surgeries, what next? Surrounded by the sights and sounds of machines that were foreign to her. She, who had never texted, had never used a computer, surrounded by these machines she did not understand. She referred to them as mechanized medicine. Her fear of mechanized medicine was huge. She was from a different generation, a generation that wasn't secure with mechanized medicine. We watched over her night and day. I spent 40 nights in the hospital, watching nurses come into her room, lab people come and poke and prod her, never a sleeping moment, always watching the machines, watching for the changes in numbers, advocating for her night and day, watching her every breath. Forced with life and death decisions to be made in hours, whether to fight at all costs or go home to die. She was a fighter. She wanted to fight until the end. The complications of home care, sorting pills that all look the same, multiple colors and shapes, and when her feeble fingers would drop the pills, we would have to sort again. The hurdles, the good news, smiles in her eyes, bad news, disappointment, sadness in her face. Overcoming obstacles and facing others, often spiraling out of control. The waiting for news, waiting for the specialist to walk through the door to give us news. What was that news going to be? The glimpse of hope in her eyes and smile when she heard the good news. All of us elated. and the disappointment when things turn for the worse. My sister's understanding and constant researching of drugs, of side effects to surgeries, understanding this and trying to help her understand this, communicating the good news, communicating the bad. The dedication and loving care of her doctors, her specialists, whose oath was to respect her wishes and fight till the end. The nurses, the physical therapists, the nursing assistants, who often gave her this encouragement and support, gave her hope to continue on. This journey was absolutely an overwhelming 1.5-year experience for my family. One that we were not prepared to ever address. It was like a train wreck, a fast-moving train with no direction, running over the tracks, bumps and hurdles all along the way. But through it all, we as a family learned about unity, about agreeing to disagree when we all had different frames of minds and different personal perspectives that we were coming from. We as a family learned how to communicate that which we knew, that which we understood, to our elder mother, who often as a patient lay defenseless in her bed. We as a family understood the person that she was, the wishes that she had, and the quality of life that she would want. We as a family would never have begun to understand and were bewildered by the experience. As she lay in the MICU, she took her last taste of pudding. She said half my name, and she remained frozen, emotionless. Her breath still going because her lungs still worked, because she had taken care of that part of her life, a stroke. We were amazed and overwhelmed when the robot rolled into the room. And there was a man in a screen who went in and out looking at her and trying to diagnose had she had a stroke. We didn't understand this. My father did not understand this, and my mother had fear in her eyes. We were joyful, a smile on my dad's face, a laugh, when the very next morning the face behind the screen came into the MICU, hugged all of us, brought that personal perspective to all of us, answered our questions, and was presently there. We knew what it meant. We knew what to do. This journey was one where our family bonded, united, where sisters with very different opinions about end-of-life issues came together. We knew the quality of life she would have and the quality of life that she would want. Never in this journey were we given a guide of what to expect with this devastating disease. We were given individual papers, booklets on perspectives about the disease, but never given a guide, which we needed, a one-stop guide to understand this personal experience, our family journey, and how to address it. Now think of our clients, the communities that we serve, the Latino farm worker, the Hmong immigrant, the Slavic refugee, the low-income, diverse ethnic communities of our region. Many having less than 6th grade education, many not being able to read, many relying on their children to understand what this meant, what they can do. The sights and sounds of the emergency room, of the intensive care unit, not understanding what this means. The language barriers, the cultural sensitivities, the spiritual beliefs, the understanding of medicine, of their bodies, and of their health. Would you understand what it meant? Would they understand what it meant? Would they know what to do? This Healthy Hearts, Healthy Lives was a labor of love. Sitting at her bedside for 40 nights, she was my best critic, my best reviewer. She would explain to me what that test felt like, what that surgery meant to her. Did she understand the surgery? She was my best author and my best friend. She was my mother. So this program was a labor of love. It's called Healthy Hearts, Healthy Lives. And the reason I put this program, it has taken a year to put this program together, was for it to be a one-stop guide for people who are living with, trying to prevent heart disease. So some of the slides I'm going to go by fast because we all know the demographics. But what I wanted to do in this speech was to really focus on the older adult, because a lot of times we might understand the patient, but the patient as a person, and most especially the older adult and the family journey. So we all know this. This I created kind of as to modify with the Healthy Hearts, Healthy Lives initiative to support the Million Hearts, Million Lives. It is kind of the patient perspective to heart disease. I admire Liz with her Be There campaign, because that campaign has so many elements of what we as a family experienced. So basically, I wanted to look first at the older adults in our population. These statistics are a little bit older because I did a talk for the American Society on Aging and had to pull this together quickly. But we've got to think that our community is growing at a very fast rate, that older adults are growing exponentially in California, that most of our older adults have multiple chronic diseases, and how do we address them? How do we know to address older adults from a perspective that they understand, that their generation understands? And how are we able to communicate health to their children so that they can be the spokesperson for their elder parent? Over 1/4 of Californians aged 45 to 70 report having high blood pressure, arthritis, or back problems, and 2 in 5 Californians have at least one chronic condition. 7 million Californians suffer from multiple chronic conditions, and that's in 2007. We know it's much more now. And then we look at the chronic diseases for seniors, age 65 or older. Heart disease is number 1, cancer, and then stroke. And all of the things that we've been working on together, this is our population. Most older adults have not used, many older adults have never used technology. Many older adults in the ethnic groups do not know how to access health care, may not have ever been to an emergency room, may not have known that they had a bad number for diabetes, and we have to think about where they are coming from. Family members are key. This just kind of goes over the ethnic background of age and ethnicity in older adults and heart disease and men. So this is the toolkit that I've designed. And it's been a year. Part of it has been released and for printing, and I'm going to offer it at the next session. But the idea was to really brand the program Healthy Hearts, Healthy Lives. So the program consists of a toolkit, a journal, and a DVD. The toolkit is focused on prevention and disease management. Then I've developed curriculum related to Know Your Numbers. And there's an overview of heart disease, blood pressure, and cholesterol. And then there's the prevention brochure, which is a simple kind of branded piece as it uses an anchor to for this patient education piece. So this is the brochure, and basically what it does is it has 10 tips for a healthy heart, healthy life. The symbols are for those people who cannot read, just to remind them of the importance of certain topics. The toolkit emphasizes strategies for each tip on that are useful for people to prevent or manage heart disease. And so these are the topics for the disease prevention booklet. And it is in Spanish and English, and it's written at a 6th grade level. Nowhere in HealthNet's arsenal of health education materials was there anything comprehensive like this. So I designed it. And these are the disease management topics, understanding and managing your heart disease. So when we are pregnant, we get a book that says what to expect when you are expecting. When you're a child, you kind of learn at school. When you're a mother, there's books on how to be a good mother. But these booklets kind of walk you through the basics of heart disease, what to expect when you have heart disease, managing coronary artery disease, heart failure and strokes, and how to avoid being readmitted to the hospital. Because the multiple readmissions were huge. This program also has a journal to help our members and our patients track how to be successful and how to maybe change certain areas of their life that may impact their management or prevention of heart disease. And I put this together thinking about all the health education programs that I personally work with at HealthNet and the various health education programs that would focus on this heart disease program. The preventing heart disease, the role I think of health educators is really to strengthen individual knowledge. And that's what I'm trying to do with many of the communities that we serve. The classes will promote the community education and get people involved in their health. This toolkit is going to be given to patient navigators in the emergency room. It's going to be given to case managers on that first visit before the 7-day follow-up. It will be an intervention that will support some of our HEDIS and STAR measures. It won't be an intervention that will solve those measures, but will be an intervention that will support other measures that we're working on within our company. And finally, I just really thank you for listening. I think this is since the time I've been at the Right Care Initiative, we're starting to really get into the basics of where our community is, how our community receives information, how to target our community, but most important, how to impact their health and their knowledge and their futures. Thank you.
We have time for maybe 1 or 2 questions. Martha, if you're willing to come back to the podium.
Yep.
Martha, are we going to be able to get this in a format that allows us to attach it to EMRs so that primary care providers can use this patient education?
So what we're going to do is the printed form for the prevention toolkit, the brochure, and the classes are going to be active, and I'm going to bring copies at the next meeting for people to pick up. So that printed documents have been released. And you can certainly ask me and we want to get it in providers' hands too, because I think it's a handbook that, regardless of your educational level or background, you can use. And then the other focus is the disease management. My hope is to roll it out next year, because that's really the meat of this program for me personally was, Mom, what did that test feel like? How do you feel after that surgery? Give me the personal patient perspective, which a lot of times we're not aware of, or we're so focused on our professional distance that we need to really reflect on and respect.
Any other questions? Well, just one quick question, Martha. So again, this is just not for HealthNet patients. This is really for.
I mean, I'd like it to be a model that other organizations would use to. Of course, I have to get permission, but the concept that other organizations would use, because through our journey, it was the health plan, it was the provider office, it was the hospital, it was the specialist. Nowhere was there a guide. Lots of individual pieces of paper that we would throw away or that we'd read and we'd forget. But this is a guide that can track, that can record, that can give you questions to ask. I literally asked my mom as she sat there, what questions would you ask about this test? What are the questions you would ask for the doctor? And we used that as a guide when we did our visits.
Other languages?
And it's going to be available in Spanish.
Spanish
and English right now. Yeah.
And then
It's a huge undertaking.
Oh, sure.
It's about 102 pages of content. not including the slides and the community classes are going to be available at the community level through community-based organizations, the provider level to do train the trainer. So the community classes also will be in English and Spanish.
I love what you're doing for the patients, and I have to say that many of us have been talking for years, but not implementing yet. The idea of giving to every patient who gets a diagnosis a beautiful book, that's a workbook that helps them through, that gives them hope, because like you said, so many people are not tech savvy in the generation that needs the help. So thank you for getting that ball rolling.
I want to know, well, this is on the heart, right? Do you have intentions of going beyond the heart and doing the other?
This was actually, what's interesting was this was actually the first enterprise-wide educational document at HealthNet, and I had to go through a lot of barriers to get this done, but it was to be used as a model for other chronic diseases. I don't know how fast that's going to happen. I got half of it printed, but we're hoping to have the disease management online. That's one of my goals. It's a 3-year plan, implementation plan, but it's a labor of love. It really is.
Great. Excellent, thank you, Martha. So now I have the distinct pleasure of introducing two of my partners at Sutter who are doing some tremendous work, and so I'm especially happy to have them come and speak about the work that they're doing. First, so I'm going to introduce Teresa Fry first, and Teresa Fry is really well known to me because she and I were in the 2005 cohort 3 of the California Healthcare Foundation's leadership program, and I got to meet her there and got to know what a passionate and wonderful individual she is with great ideas and tremendous leadership skills. And you'll hear more about the work that she's done because this will be the topic in patient safety, and she's a leader in the nation in patient safety, and we're very fortunate to have her at Sutter. She's currently the Chief Operating Officer for Sutter Medical Foundation, and so she leads the 9-county region for SMF here in Sutter, and we're happy to have her. And joining Teresa right after her will be Tori Starr. And Tori Starr is our Chief Executive for Care Coordination in the Sacramento region. And again, I'll let you read all his, because all of our presenters today have great experiences, and I won't belabor the point other than to tell you that Tori and I work very closely together. I just introduced him as my boss because he has Ralph, you'll need to acknowledge that Tori has a lot of direction that he provides us and is very innovative in the work that he's doing around care coordination and around care management. And we really rely on him and all the work that he's doing to help us. And he's going to spend some time talking about care coordination across this region and the work that he's doing. So we're really excited. So I'll let Teresa come up first and talk about the coalition that she leads.
Thank you. Jose and I, and actually Tori as well, are graduates. This is a little advertising from the California Healthcare Foundation Fellowship Program. It's a fellowship program that is mostly funded through CHCF, and it brings together healthcare leaders from across the state in a 2-year curriculum. And Jose and I met there, and I was so impressed with his dedication of primary care. And at that time, he was actually helping with the faculty practice. And I was so thrilled that when I moved my job to Sacramento that I was going to be able to work with Jose a little bit closer, because I've always been impressed with him as a physician leader. So thank you for time on the agenda. What I'm going to do is just take 5 minutes of your time to tell you about the California Patient Safety Action Coalition, with the purpose of potentially engaging a few of you who may not know about this and potentially participating in a collaborative around medication safety here in Sacramento. And Hattie, thank you so much for time on the agenda. Hattie has been a partner and supporter of the California Patient Safety Action Coalition. Gosh, I think it's 2008 when we connected, and she's just been a great help. And I'll turn it over to Tori. Tori's going to touch on a program that he is leading among the Sac-Sarah region that is really trying to kind of bridge medication safety
And Martha, I was so impressed with your story, and I just want to thank you for sharing. I know it's really hard sometimes when you're that close to an experience to share, but there were so many different threads that I picked up on it that, you know, kind of makes me recommit to patient safety. The discussion of the infection that your mother had that ended up in endocarditis, all of the mechanics of how complex care is delivered in a hospital today, and then the medication safety at home, so how we can bridge all that is really what CAPSAC's trying to do. We came together in 2007 because of the mandatory adverse event reporting law that went into place because of Senate Bill 1307, and we weren't too sure how the public was going to respond. So we partnered with CVPH, and there's about 60 organizations across the state that come together. And this year, we actually reconfirmed the mission, and I sent these kind of late, so they'll be posted on the website. But really what we're trying to do is provide a forum for organizations to address patient safety and leverage change across the healthcare continuum based on principles of fair and just culture. And really there's 3 areas that we consider our pillars. One is to provide opportunities that are very similar to what Patty's accomplishing here, I think with both the co-chairs, which is a forum for best practices. And actually, I know because I work across California and I've worked with a lot of California health systems, we are very competitive. So when we see a best practice and we see best numbers, I'm telling you that each one of us, whether we're Mercy or Kaiser or Dignity or VA, we go back and say, I need my numbers to improve. So this kind of forum, we're not as robust, we haven't got the funding, so we're going to be looking at that. But what we're actually doing is we're kind of pivoting on what we've been working on. We partnered with David Marks from Outcome Engineering and Strike Concepts of a Fair and Just Culture, which is really trying to look at the behaviors that folks choose instead of choosing the right path, you know, that they don't understand the relative risk. They might not make the right choices, and how do you evaluate that? We're now focused on the human error and the system design. The University of Wisconsin in Madison was given an art grant many years ago, and they put together the System Engineering Initiative to improve patient safety, and they have done rich, robust research on the best way to approach medication safety and other things that are impacting the care that's delivered both in the hospitals and in our ambulatory care settings. So Dr. Pascal Carrion, who is the chair, she is at the University of Wisconsin School of Industrial Engineering. She is going to partner with us. I didn't have anything formal to present today because I am still working through the logistics of working with CVPH. Kathleen Billingsley has been a great partner with us. And we really want to partner in Sacramento because I think that we can leverage potentially folks in your organizations to come together around this very important initiative. We had a discussion about a month ago about how this could potentially impact what you do for heart patients, what you do for stroke patients, because we all know that when they leave the hospital, that there are many times that directions that they get are fundamentally unable to be executed on when they get home. And then they end up back in our hospitals. We also know that we could probably connect better as health systems serving an entire community in Sacramento around medication safety, and we could learn together rather than learning separate. So I'm going to turn it over to Tori at this point, so he can tell you more about the care coordination program. So thanks, Hattie.
Thank you, Teresa.
Well, thank you. It's a pleasure to be here today. And when I first was contemplating, I've only been with Sutter about 18 months now, and when I made the decision to take the job, was actually because I reached out to Teresa, being an alumni from the CHCF leadership.